So this is Dr. Isabelle Amigues, your friendly rheumatologist who is French, I cannot hide it, and lives in Denver, Colorado. Such a pleasure to see you today. And we're going to talk about inflammatory bowel disease related arthropathy. This is a question that comes from Barefoot by the Creek 4859. And it seems like it was important for Barefoot by the Creek 4859 as you've asked the question several times, and I think it's a very, very important question. And so, what I wanted to discuss today is what is inflammatory, what is arthritis related to inflammatory bowel disease, why it's so important to know about them, and how we diagnose it, and what it is basically. So, first of all, um, what is inflammatory bowel disease? Then I'll tell you a story, and then we'll go into what is inflammatory arthritis related to IBD. So, inflammatory bowel disease, or IBD, is different than IBS, which is irritable bowel syndrome, or you can even, so inflammatory bowel disease, irritable bowel syndrome. In inflammatory bowel disease, you actually have such severe inflammation that you develop blood in the stool, that you can have mucus in the stool, and that basically you can develop some very severe infection, severe inflammation, severe blood loss, and it's really problematic. Really, the cool thing is that we have very good treatments. Okay, so I mean, definitely not treatment that I will offer as a rheumatologist in the sense of that's being seen by the gastroenterologist, but it's still very, very cool to know that a lot of those treatments are very similar to the treatments that we in rheumatologists do. So there is two types of inflammatory bowel disease. There is the hemorrhagic rectocolitis, or ulcerative colitis, or UC, or there's Crohn's disease. UC is more the rectum, the anus. That's usually what's touched, and Crohn's can touch everything. In those two inflammatory bowel disease, you can have a lot of other association related, basically, that may be due to the inflammatory bowel disease, or maybe its own condition. So, what I want to explain now is how a rheumatologist think when we have someone that comes with an inflammatory arthritis and has also an inflammatory bowel disease. So I'm going to tell you a recent, not so recent actually, a case because I think it will give you an idea. So I had a patient several years ago who came who had. Did I make the diagnosis of inflammatory bowel disease? I think I made the diagnosis of inflammatory disease of IBD basically. But basically, he had joint pain. He was 25 to 27. Had joint pain, but it was not symmetric. So he had like a full finger here, a toe there. He had his back pain that was inflammatory. And basically, when you see this, you're always wondering if it's called a spondyloarthropathy. Spondy for spine, arthropathy for disease of the joint. Okay. And so for me, in my head, I was like, well, that looks like spondyloarthropathy. Now, my question is, what other disease does he have? And so that's also very important because imagine Venn diagram, right? If you have one, you have to think of the other ones. I wish I had a paper for you, but just imagine like circles here. All right. And they are all different diseases. And those are the diseases that we are thinking about. If you have a spondyloarthropathy, and we think of an inflammatory bowel disease, then we think of, do you have psoriasis? Sorry, I never say it properly. Do you have psoriatic arthritis? Do you have reactive arthritis? Do you have eye inflammation called uveitis? And those are like the main one, right? So when someone presents with any of those, So let's imagine he has uveitis. We're going to think of all of those. Let's imagine they have inflammatory bowel disease. We're going to think of all of those. If they have a spondylarthropathy, we're going to think of all of those. And so basically, our job as a rheumatologist is to say, okay, is this just a spondylarthropathy? Is it just what we call ankylosing spondylitis? Or is this associated with psoriasis? Or is this associated with uveitis? Or is this associated also with inflammatory bowel disease? And that is how we think. And then once you have made this, you can basically say, okay, well, so in the case of this young patient, he had blood in the stool and he had pain in the abdomen. And so I sent him to a GI doc that confirmed the diagnosis of inflammatory bowel disease. And then because he had spondylarthropathy, so inflammatory arthritis of the back, as well as some peripheral joint, and had also GI, like inflammatory bowel disease, then we start treatment that's going to take care of both of those things. Okay. So I think the most important thing is to think that they are all part of the same family. A lot of them have a HLA-B27, but they don't have to have HLA-B27, which is a genetic marker. You do not have to have HLA-B27. And also, you can have HLA-B27 without having the conditions. So that's important. 5% of the population has this HLA-B27 without having the condition. So that's important. Now, to respond to your question let's talk about IBD-related joint issues. When you have inflammatory bowel disease, and that's the main problem. So you have Crohn's or you have ulcerative colitis, and that's what you started with. And then you develop joint pain. There's two things that we think about. No, three things. Number one is, do you have an infection? Right? So that's important. Is it just one joint? If it is just one joint, you have to go look at the fluid, the synovial fluid, to see and to make sure that this is not an infection. If you have more than one, if you have like 2, 3, 4, 5, 6 more, then it's probably not infectious, which is great. Okay. I mean, it's not great or not great. We have treatment that are just different, right? If it's an infection, you want antibiotics. If it's related to inflammation, you want an immunosuppressive agent, right? So it's not bad, wrong. Like there's nothing like that. It's just, what is it, so we can treat it properly. So let's say you present with inflammatory bowel disease and you then develop joint pain, and it is inflammatory. Worse in the morning, associated with morning stiffness. So morning stiffness, when you feel like you have to have oil and like move your joint until they actually function. And then it's improved with exercise. Those are like 3 questions. If you respond to yes at any of those 3, you have an inflammatory arthritis. Then you have to wonder, is this its own thing? So is this a spondylarthropathy? Or is this related only to the ulcerative colitis or IBD or the Crohn's, right? So to do that, you're going to actually check what type of joint are involved. Do you have joint pain in your back? Do you have any inflammation in your back that we can see on an X-ray or an MRI? And then basically we're going to say, okay, well, yes, we think that you also have, so if you have psoriasis, for example, you have psoriatic arthritis and inflammatory bowel disease, or that's when it's become tricky. Is this inflammatory bowel disease related arthropathy? So that's, so 2. Number 1, is this an infection? Number 2, is this an inflammatory bowel disease related arthropathy or like a spondylarthropathy? What is it in the 2? And then the third one is this related to treatments that you're taking for the inflammatory bowel disease? Because there are some treatments that can potentially cause pain. Once you've made that distinction, right? Once you're like, okay, well, it's not an infection. That's great. Like that's the most important question that we can answer, right? And then we're like, okay, you are treated. Let's say you're treated and you're doing really, really well from your inflammatory bowel disease, because that's the thing. You may be perfect from your IBD, and then you develop this very inflammatory arthritis. we need to treat the inflammatory arthritis. So then the rheumatologist and the gastroenterologist are going to come together and they're going to say, look, let's pick the treatment that's going to work for both of those. So there are some really powerful treatments in rheumatology that do not work for inflammatory bowel disease. And on the other side, there are very powerful treatments for IBD that do not work for inflammatory arthritis. And this is the good news, there are also very powerful treatments that work for both. And so that's what we would do. We would basically put you on a medication that works for both. Okay. The thing that's really interesting is that when we have an inflammatory arthritis associated with IBD, it's not necessarily a sign that your IBD is not properly treated. What I mean by that is that sometimes they go hand in hand. So you have a flare of inflammatory bowel disease and you're going to have a flare of the arthritis. But very often they have no association. You're going to have an inflammatory bowel disease flare, no joint issue, or you may have no problem with your inflammatory bowel disease and you will have a problem with your joint. And so our job is to figure out what to do at that moment. And that's not the easiest thing to do. So that's actually a really, really, really good question, because it's not the easiest thing to do. But the good news is that most of our treatments can work for both inflammatory bowel disease and for inflammatory arthritis. Okay, so this patient that I was telling you about basically confirmed that he had inflammation of the sacroiliac. So we confirmed that he had, and he had HLA-B27. So we confirmed that he had ankylosing spondylitis, and we confirmed that he had inflammatory bowel disease. The main issue for him was actually his inflammatory bowel disease. And once we controlled that, he actually never needed anything from his inflammatory arthritis. So he's been doing really, really good. And it's been really wonderful to see. So yeah, and what I had told him at the time is that if he needed something for his inflammatory arthritis, we had a ton of treatment, because that is really true. All right. Well, I hope you enjoyed this. If you're watching this on replay, don't hesitate to put #replay. Hi, TeleWellMD. Thank you for joining. And I hope you enjoyed those. If you think that they are useful, please share them. It's my pleasure to share this with you. I really am passionate about teaching rheumatology. Hopefully, I don't go into too many technical words that you cannot understand. So please let me know if it's too technical. Let me know if you would want more technicalities as well. And I will see you next week. And let me know what you want us to talk about. I pick all of those out of your comments. Thank you so much, everyone, and see you next week. Bye-bye. And happy 4th of July weekend. Bye, everyone.